Today we're going to take a look at technologies that are available commercially that allow us to perform more objective clinical evaluations for our patients, and how those new technologies have taken us well beyond what we could do with traditional bedside testing. We're going to be focused on the vestibulo-ocular reflex. So we're looking at how we can assess the VOR and how we can use that information for our rehabilitation protocols. I'll show you quickly how this test was originally done bedside, and then how we can do it more objectively now with our advanced computerized protocols, and then we'll look at how we can use that information to help us better develop treatment protocols for our patients. After the quick recap here, then we'll have some follow-up presentations that will take us much deeper into DVA and GST in the clinic. So what is the vestibulo-ocular reflex? It is that reflex that allows me to keep my vision focused on a target in front of me while I'm moving my head. So as I move the head to the right, my eyes are driven to the left, moving equal and opposite, so that I can stay focused on the target in front of me. It's very important that this reflex works so that our world can remain stationary for us while we're in motion. What we don't want to happen is what you see here in this textbook video, right? So the letters are bouncing all over the page. It's called oscillopsia. When the VOR isn't working correctly, the patient or the person's world and vision is very blurry, and so it makes it very difficult for them to get through their everyday living activities. And so we want to be able to properly assess this VOR and make sure that the patient's world is as stationary as it can be during these head motions. We have clinical assessment tools: video head impulse test, caloric, rotational chair, VOR cancellation. These tests use a head sensor, so a device that measures the head motion, as well as recording devices for the eyes. So we'll be looking at where are the eyes in relationship to where is the head. We also have functional assessments like dynamic visual acuity, DVA and gaze stabilization testing, GST, where we still will be monitoring head motions, but using, instead of recording the eye movements, we'll be using feedback from the patient. So the patient will be looking at a symbol in front of them and telling us information about that symbol. For example, which direction is it pointing at? So the patient providing us the feedback on the acuity, the visual acuity, while the head monitor or the head sensor is measuring the movement of the head. Here's an example of Dr. Sharon Cushing doing dynamic visual acuity in the bedside manner. So here she has a chart on the wall. This young patient is reading this chart until he can no longer repeat the letters back clearly. Then she starts to move his head and then asks him again to read the chart down from the bigger letters to the smaller letters until he can no longer read the letters clearly. So using a Snellen chart, you can also use symbols for children that are too young to be able to know the alphabet. A patient is standing 10 feet away from this chart on the wall. First up is the stationary, so they don't move their head, just read the line. Then we start shaking their head. Again, we ask them to read the chart down till they can no longer see it clearly. If there is a 2 to 3 line difference between the static score and the head movement score, then we know that they have a problem with their VOR. This could be either a central lesion, a bilateral weakness, it could be a cerebellar lesion. So it's really important that we be able to get a very accurate assessment of this VOR so that we can make the correct diagnosis. There are limitations to bedside testing. The most obvious ones are that there are no objective measurements, and so everything is subjective, and that makes it much more difficult to compare scores from visit to visit, so it's hard to monitor the progress. There is no, or at least very limited, uniformity among how different clinics do the tests, so it's hard to compare from clinic to clinic. And of course, subjective measurements are never going to be as sensitive or as accurate as are these computerized algorithms that we have in the newer systems that are available today. In order to measure the head movements, we need to have this little sensor that you see there on top of the goggle. So this sensor is an inertial measurement unit, so it records all the head motion data, and then it's either attached to the goggle if you're going to be measuring eye movements in regards to head movements, or it can be on a little headband, as you see in this lower picture. The headband, when we're not recording eye movements, we will mount it to the headband so the patient can wear their glasses if they need to, and then we can get better visual acuity. If we're not interested in the eye movements, like in DVA and GST, where the feedback is coming from the patient, so the patient's going to be reading back the symbol for us, so we don't need to be recording the eyes. So we just need the head sensor and the patient to have the best vision that they can have before we start the test. What is the benefit of adding this to my clinic? The first and obviously most important benefit for me is that it's nice for my patients to not have to be referred out for other testing. So we prefer to keep our patients in-house for as many tests as we can. Our patients prefer that too. They don't like to have to go to 5 different places for 5 different tests. So it's really nice for patient compliance, and it makes the patients feel good and comfortable that they're getting everything done in one location. It's also nice for me as an audiologist to be able to provide more functional assessments that can help in the rehabilitation. And then, of course, that objective measure of patient progress. These tools are nice because I can monitor my patient's progress from visit to visit. So here's an example of a dynamic visual acuity test. So we can see that the patient was seen over several visits up until 3 weeks. On the first visit, this black dot represents his static visual acuity score. And then I start moving his head. When I move his head to the right, did okay, it's just on that gray abnormal line. But when I moved his head to the left, you can see that his score is way up in the gray area. So he has a lot of difficulty keeping focused on the target when his head is moving to the left. We see a little bit of differences in the vertical. You can also test in the vertical plane. And then he goes away and does his rehabilitation, his home exercises. He comes back again 1.5 weeks later, and we can see that all of those scores to the left are dropping into the normal range. I even tested a few extra frequencies just to be certain. And we can see that he's getting better, but it's not all the way better yet, right? Still kind of in that gray, bottom of that gray area. And so off he goes for more rehabilitation and more home exercises. And then at the end of the 3 weeks, we can see that all of his scores are normal. So it's a really nice, very accurate and objective test that allows me to measure the patient's progress over time. It's similar for the GST test. In the GST test, the optic type is always staying the same, but I'll move the patient's head gradually faster and faster and faster till I can find the speed where he can no longer see the target clearly. And so you can see for the left at 130 degrees per second, the target's already getting blurry, where to the right he can go up to 200. So we see this asymmetry. And just another example on the other side, just exactly the opposite. This patient had difficulty moving to the right. That value that you see there, 105 here to the right, that value where the patient can no longer see clearly, that is a very important number, because that is the number that the physical therapist or whoever's doing the rehabilitation for that patient, it's the number that they need to know where to start the rehabilitation. So it provides us with really good information that we can use to get that patient started in the correct rehabilitation program. Which patients do I test? Pretty much any patient that tells me that they have lightheadedness or dizziness, and especially if they say that this happens more when they're moving their head. So anytime anybody tells me, I guess I'm really dizzy when I move my head, then they're a good candidate for DVA and GST testing. There are some more advanced computerized posturography tests, like the SOT test, that can also predict for us or suggest for us when we might do DVA and GST. Medical legal reasons, sports enhancements. A lot of times athletes can pass the traditional tests, but if we start to challenge them a little bit more with these faster high-speed tests, we can start to see a breakdown. So it's a very practical test for many, many cases of dizziness or lightheadedness or imbalance in patients, especially when that imbalance is enhanced with head motion. And why do we want to isolate these impairments? Because they help us with our differential diagnosis, whether it's a vestibular disorder or concussion, traumatic brain injury. It's a really great tool for the elderly folks who have multifactorial disorders, CVA, neurodevelopmental disorders, and again, nice tool for those high-performance athletes. So what, again, is important from these tests, and here I'm giving an example of GST, is that breakdown value that I showed you, where that head speed, what head speed do they start to have blurring, because that's what we need to know in order to be able to set up that home exercise program for them. And our goal is always to be able to get that person as stable on their feet as we can so that they can participate in everyday activities without the risk of injury or fall. And you can see that very nicely in this picture here of a patient in rehabilitation going from a walker to be able to freely move with her cane. So our goal is always to be able to get the patient to perform as best as they can, and knowing where they break down and being able to monitor that progress over time only helps us to better give them more appropriate treatment programs. Quick recap on the differences between GST and DVA. Remember that in DVA, the optal type is getting smaller and smaller and smaller, but the head speed is constant. Exactly the opposite for GST. For GST, the optal type or the stimulus is always the same size, but the head's getting faster and faster and faster. So they're very similar. Both are looking at visual acuity during head movements, but the DVA is more focused on visual acuity loss, while the GST is more focused on functional impairment and at what speed does the retinal slip occur. Both of them provide great information to help us develop our rehabilitative protocols and to monitor compensation over time. So I'm going to take questions and end this session here. This was just, again, a very quick recap, overview of what is the VOR and what are we testing and the differences between bedside testing and computerized DVA and GST tests. And then shortly, we will take a deeper dive into how these tests are used in the clinic. And I thank you for your time.